Hello everyone, and welcome to the Henry Schein webinar series on COVID-19. I'm Dr. Gary Severance with Henry Schein. And just like we do every week, we're going to turn it over to Dr. David Reznik for a clinical update. But we'll follow that with a little refresher on the air management processes and showcase some of the products or solutions that Henry Schein offers. But now, Dr. Reznik.
Thank you, Gary. And as always, it is a true privilege to be a part of everyone's journey as we reopen our offices and start to provide care and do what we know how to do best, which is to eliminate oral disease, restore function, and make people smile. So today we're going to talk about something that might be a little different. If you've been watching this series, you might know something different about my face today. And that is, I have shaved. For the first time in 6 years, I've actually seen the rest of my face, and the reason I did it was plain and simple. For me to put on an N95, for me to safely treat patients, for me to safely do diagnostic work or anything that might possibly produce an aerosol generating procedure, I'm going to have an N95 on. And for the N95 to work, I need a tight seal. And even though I really only had long stubble or a 3-day beard, I needed to ensure for the safety of those I work with, and those in my family, and those I run into during daily business, that I'm protected. So that's why you're seeing a different me today. And we're going to talk about some of the different facial hairstyles and filtering Facepiece respirators and what works and what doesn't work. I'm not going to go over all of these. I had seen this slide before, and I think that it's probably time for us to share it. If you look, it really is the chin area or the side. So any place that the N95 would fit is the area that we're concerned about. So mustaches, for the most part, are going to be fine. Soul patches are going to be fine. I'm not exactly thrilled with what they call the toothbrush style here, but you can see certain kinds of facial hair do work, certain kinds don't work. And the object is, again, if you're wearing a tight-fitting facial respirator, that you have a good seal, and you can't do that with hair. So enough on that. Let's go to where we are with the disease in the country. As you know, we're seeing less cases. I am very pleased to say that at the hospital I have spent almost 3 decades at, we have the lowest number of hospitalized patients with COVID right now that we have since the beginning of the epidemic. So we've seen a reduction in the level of influenza-like illness, which could be suspect for COVID, and COVID-like illness, and the percentage of specimens who are testing positive for SARS-CoV-2, the virus that causes COVID-19. And we see the either continuing to decline or remain stable. Mortality as well has also decreased compared to last week, but remains elevated above baseline. So it's not that we're out of the woods yet, we're just seeing a reduction in the cases. The national percentage of specimens testing positive for SARS-CoV at public health, clinical, and commercial laboratories decreased from week 20 to 21. Again, excellent news. Looking at the percentages by the type of laboratory where these information were shared from public health laboratories, there was a decrease from 8.4% to 7%. Clinical laboratories, again, 6.3 to 5.6. And commercial laboratories, 7.8 to 6.9. What we're seeing in all laboratories is a decrease in the number of positive tests. Again, great news for us. So there are some key points I'd like to talk about, and there are 2 areas where we've actually seen an increase. And that is, regretfully, where I live in the Southeast, Region 4, and Region 10, the Pacific Northwest. So it's really important as we try to judge the level of risk, even though we're going to have to incorporate our newfound standard precautions, which are going to involve an N95 for aerosol-producing procedures, that the amount of risk that you face could be based on where you live. If you're in a very rural area that's had very few cases, then you're in a different position if you are in New York, which is just opening up for dental care. So it's just based on where you live, and you need to stay aware of your environment. If your community is experiencing limited or minimal or no transmission, you can provide care to patients without suspected or confirmed COVID-19 using strict adherence to standard precautions. And we have been implementing standard precautions for quite some time now, so that shouldn't be anything new for us. However, we do know that patients can present either asymptomatic or pre-symptomatic, so it really is recommended that dental healthcare personnel wear enhanced infection control, and to me, that really means using your doffing and donning techniques and wearing that N95. No to minimal community transmission is defined as the evidence of isolated cases or limited community transmission, cases under investigation, and no evidence of a large exposure in a communal setting. I think we're all a bit concerned with what's been going on in society, and we're all sort of worried that doing our peaceful protesting or protesting which is appropriate, that there might be an expansion of coronavirus. So something else to keep in mind depending on where you live and what the situations are. If your community has experienced minimal to moderate or substantial transmission, and there still are areas where we have minimal to moderate or substantial transmission, you can provide care without suspected or confirmed COVID-19 using the considerations to protect both the dental health care worker and patients. And I think that's always what I've been focusing on. No matter what we do and no matter where we live, we really should take all the precautions necessary to ensure that we're providing safe care for our families, our patients, and our staff. So the key points of the CDC's latest summary is that the overall cumulative cases, or the hospitalization rate, is 73.3% per 100,000. The highest rates are for people over 65, and I'm actually going to go into a bit of detail on the age breakdown just to give you a better idea. We've always talked about people over 65 and then, the younger group. So what are really those numbers? And we'll go into that a little bit today. Non-Hispanic Black and non-Hispanic American Indian or Native Alaska Native populations have a very high rate. They're 4.5 times that we see from non-Hispanic whites. The same thing, we're also seeing an increased rate in the Hispanic Latino community, which is 3.5 times that of non-Hispanic whites. So once again, we're seeing health disparities show up where there are people who are African American, Native American, Hispanic Latino are being hit harder by this pandemic than Caucasians or whites. If you look at the hospitalization rate based on age, you can see a breakdown here that's a little bit different. If you look at the number between 18 and 49 years of age, that is 41% of the hospitalization rates. That is a significant number. Now, as you can see, as you get older in that age grade, it's going to be higher. So if you're between 18 and 29, it's only 20.1 cumulative rate per 100,000 in the population. But if you look at 40 to 49, it's 68.5 per 100,000 population. Then the next group we look at is the group that I still fall in, and I'd love this little range because I still fall in the group, of 50 to 64, the rate is 113.4 per 100,000, and then, of course, the group that we've been the most concerned with because of things that have happened in nursing homes and to elderly and members of our own families, you can see that rate for 65 plus years is 229.7, and then if it's plus 85, the hospitalization rate is significantly higher at 426.7. So I did want to give you a range. I wanted you to see that this just is not impacting people who are older than I am or older than you are. It's impacting people our age. It's impacting people who are younger than us. It is impacting certain populations more, but it's impacting all populations. So therefore, all of those enhanced infection control procedures that we've talked about over these last several weeks still must be maintained. Another addition to our list of guidelines comes from the American Dental Hygienists Association on their guidance to return to work. And I do want to spend some time talking about that. These guidelines were put together based on the CDC guidelines that were recently released that we covered last week. And they have some different additions there which are worth talking about. OSAP was also very involved in helping put these American Dental Hygiene Association guidelines together. So I thought it was time for us to talk about those. In order to protect dental hygienists, the dental team, patients, the American Dental Hygienists Association continues to support the recommendations from the CDC that balance the needs to provide necessary services while minimizing risk to patients and dental healthcare personnel. The following considerations have been prepared utilizing guidelines, regulations, and resources from key resources including, but not limited to, the CDC, Occupational Safe and Health Administration, or OSHA, the ADA, and the Organization for Safety, Asepsis, and Prevention, an organization that's very dear to me, OSAP. So what does the interim guidelines have? Prior to returning work, all dental team members should be tested for COVID-19 where feasible, and I think that's key. So in my situation, working in a hospital, all of my staff that wish to be tested have been tested. And actually, I'm in an environment where we are able to do blood draws and to actually look for antibody testing. But as Dr. Fauci said this morning, in the news, or this week on the news, he basically said that, yes, we can form antibodies, but we don't know how long those antibodies are going to work. So that's something that when we look at other coronaviruses, that the antibodies might work for a year, so we're still not exactly sure where we are with that. Individuals who test positive or present with symptoms should not report to work and should follow quarantine protocols. You know, that's an issue that's very big. When you are sick, you need to stay home. And as I've mentioned in the past, a lot of times that doesn't happen. People don't want to use their time off, or they can't afford to take the time off, or they've been out of work for a period of time. But if you are sick, please stay home. If there's a surge in your community of COVID-19, which is very probable. We don't know that this is going to go away in the summer, as we talked about before, because we're in the summer. We do have reduced cases, but it has not gone away. Then consider providing emergency services only. Continue monitoring the risk level. There may be times when it might be important to cease non-essential procedures if there's a surge. And again, that's based on where you are, your environment, and keeping up with what's happening in your own communities. The most important thing, or one of the most important things, is communication. Communication with the dental team, communication with your patients, communication with anybody who has questions about that. But when you're talking from the dental hygiene perspective, meet with your employer and the entire dental team to have an open conversation. And we do that actually here every morning. Do we have enough PPE? Do we have the supplies that we need? We're getting ready to open up for some endodontic procedures. Do we have all of our endo here? And now that's not from the hygiene perspective, but that's from the dental perspective. Screening practices for COVID-19. So we are actually going to have a person outside of the dental clinic who will be asking a series of questions, a little bit more than do you have we'll do the fever, the temperature check, 100.4, remember that's the number, shortness of breath, and a dry cough. But we'll go through all the symptoms, ask if they've been around somebody that's had COVID-19, and so forth. So we're going to do a pretty good pre-screening when patients present. But you can screen before they get there. We're going to use methods to eliminate aerosol production in the office, and that is an important strategy because aerosol is our big concern at this point. Talk about strategies for social distancing among patients and the dental team, especially amongst the dental team. It sometimes becomes difficult because people group up and they want to have conversations. So how do you form people doing social distancing? And so since I'm in a hospital environment and when I'm outside of my office, everybody has to have masks on. So that's one of the ways that we're doing that. Scheduling changes for providers to allow appropriate disinfection between patients. As someone who believes strongly in infection control as a means of providing the safest visit possible, you have to take that time. And then you need to have one person, and I actually have two at this time, who are identifying or monitoring national resources and updating the entire dental team on key recommendations that will impact practice, including the ADHA's COVID-19 resource system. Patient preparation. This is a time we can use teledentistry, or we can pick up the phone and screen our patients before they come in. If a patient reports symptoms of COVID-19, avoid non-emergency dental care. If possible, delay dental care until the patient has recovered. These are some recommendations that the ADHA came up with that are in addition to what the CDC has recommended, and they're excellent recommendations. Pre-screening of patients will reduce the number of in-office patients as well as post-treatment follow-up appointments. So if you can pre-screen and somebody isn't feeling well, go ahead and reschedule them and fill the slot. If forms need to be completed and signed, and to be frankly honest, I've gone paperless here, provide pens for the patient and instruct to keep the pens for their personal use. So another marketing tool. If you want to use it, you can put your office name and phone number, etc. on the pens. Special considerations for providing dental hygiene care. High volume evacuators should be available in dental hygiene rooms, and a dental hygiene assistant should be available during procedures that require high volume evacuation. Now, what I have done, to be frankly honest, is I have bought a system that will enable the dental hygienist to perform their services with high volume evacuation. However, since we're not at full speed, and I do have staff members here, we are providing, at least at this point, for our hygienists, we will provide assistance. Will it be available, or will I be able to do that when we get into full mode? Probably not, but right now we are, and we're getting used to the systems that we have. Use hand instrumentation versus the ultrasonic. Remember, the CDC's guidelines was pretty strong on that. Do not use the high-speed ultrasonic scaler. So you can use hand instrumentation for periodontal debridement and scaling procedures. I'm a little bit concerned that we don't want to overuse because of the repetitive motion. As someone who's worked in HIV for years, I also know that a lot of the incidents that do take place or exposures are from putting too much torque on hand instruments. So if you're used to using the high-speed ultrasonic and just using hand instrumentation for minor cleanup, it might be good to limit the number of quadrants that you start with just at the beginning. Use selective plaque and stain removal versus full mouth coronal polishing. I could not agree with that anymore. There have been times that patients have been scheduled with me for restoration that I didn't agree with needed to be done, and I did not want to waste the patient's time for coming out here, so I would go ahead and clean their teeth. And it would be amazing, even with my wonderful dental assistant, how much splatter the polishing can cause. So I completely agree with this. Avoid air polishing procedures. I think that's pretty much common sense. That stuff does go everywhere. And do not use the air and water functions of the syringe together, because that can create an aerosol. Fit testing for N95 facial respirators. Please remember that OSHA requires initial fit testing for new employees. Right now, the annual fit testing for existing employees has been waived. But the best practice for respiratory protection involves the use of N95 respirators custom fitted for critical tasks. So training on fit and seal should be provided prior to use, and other masks may be used for non-critical tasks. But the least level of a mask I'll have used in here will be a level 3. That protects you from fluid. Remember, N95s, they protect you from particulate matter. A little bit different than what we have seen from the other guidelines is the request to remove the respirator after each patient. Now, when you do that, it's very careful when you doff it, when you take it off, that's not going to be the issue. It's when you put it on, please be very careful with hand hygiene because you don't want to contaminate. Fit testing kits are actually available commercially. Now, I don't know how available they are today. I'm not the manufacturer. I'm the expert, but I do work in a hospital, and we do have that available. There are advantages to this incredible facility that I've worked at all these years. But when you buy one of these tests, please follow the manufacturer instructions, but realize that fit testing doesn't need to be done by an expert. It could be done by an employer or an outside party. It should be done annually just to make sure that you get a good tight seal. And it uses an agent, something that you could smell, to check whether there's leakage. So really what you're looking is to make sure you get that tight seal, which again is why I no longer have my professorial look. Remove and discard disposable respirators and surgical masks. So between each patient, if you have a surgical mask, it needs to go in the trash. We are doing things to protect our respirators for extended use of the respirators, since the availability is still questionable in many parts of the country. And then whenever you take off a mask or a hand hygiene, or whenever you take off a mask or a respirator, or whenever you take off gloves, it is truly important that you perform hand hygiene. So OSHA's recommendations for N95 reuse past shelf life, I thought I would add this in. When alternatives are not available, or where their use creates additional safety or health hazards, employers may consider extended use or reuse of N95 respirators, or use of N95 respirators that were approved but have passed their manufacturer's recommended shelf life. And, we're very concerned about having, especially now since we've been down, we're going through all of our supplies to making sure they're still in date. But for N95s, there are certain times you can use them which is past our date. So NIOSH has actually tested some N95s that are beyond their manufacturer's dates from facilities across the country, and determined that certain N95 models continue to protect against hazards which they would ordinarily be appropriate. So 95% of the most penetrating particles, and that's actually excellent news. In the event of extended use or reuse of N95s becomes necessary, the same worker, not different workers, this is common sense, is permitted the extended use or reuse of the respirator as long as the respirator maintains its structural and functional integrity, and the filter material is not physically damaged, soiled, wet, contaminated, or written on. Extended use is only preferred over reuse due to contact transmission risk associated with donning and doffing. So we talked about the little difference between the ADHA guidelines, which to take them off, which I'm really not completely opposed to that concept, because many people have difficulty breathing through the N95 or it's exhausting. And if you can doff them and don them safely, then fine. But really what NIOSH has said is that they would rather you have it on for an extended period of time. When respirators are being reused, employers should pay particular attention to the worker's proper storage. This is not something that goes into lab coats. This is not something that goes into pockets. This is something that really should go into a labeled paper bag and stored safely. When not to use expired N95s, generally must not be used for us when we are performing aerosolized procedures. So if we're going to do anything that's going to generate an aerosol, please make sure that your N95 is in date. If you are doing exams, if you are doing procedures that will not be aerosol producing procedures, partials, dentures, things of that sort, then it's perfectly fine. But if you are taking out a handpiece or polishing a few extra areas, then at that point you really need to have an N95 that is in date. This is the one area where I have a little bit of a disagreement, but a lot of people have laundries in their offices, and they leave their scrubs in their offices and have them laundered and then change clothes, and then are able to come back and change clothes. And if you want to leave a pair of shoes in work, then that's perfectly fine. What we're doing here is we're putting on footies. We do know that the bottom of a shoe is actually, if you think about it, the droplets land on the floor, some aerosol could eventually settle on the floor, and even though we're using some wonderful filtering devices, and I understand you might be hearing about some new devices today, we don't want to bring it into the house. So literally, I'm instructing staff to, and we purchase them now to use footies while they're in clinic, and when they leave clinic, even just to be in the building, to take the footies off. When they go home, take the footies off, immediately discard. Patient scheduling is something we need to look at too. It should be allowed for a manner that allows for complete disinfection of the operatories, if possible. Again, depending on the size of the program that you're working in, choose 2 rooms for each dental hygienist to use, so one that can be sanitized and prepared while the dental hygienist begins to use the next room. Either that, or you're going to have longer appointments, and then the room is going to have to sit for 15 minutes. So if there's only one room dedicated, then the period of time is going to be longer. It's recommended by the American Dental Hygienists Association to increase the appointment time to 1.5 hours to allow for appropriate disinfection and room preparation. Do not double book appointments. And so this is standing with the CDC guidelines. None of this is really different, except that scheduling time and how you're working on scheduling truly is up to the office and the speed of the hygienist and the safety of the hygienist. And as a communication between dentist and hygienist and assistants and team members, that could be developed on your own. There is a wonderful dental hygiene readiness to return work chart. Meet with coworkers to discuss strategies for reopening the practice, doing inventory for PPE and sufficient supplies, having dental team members tested for COVID or exhibit no signs or not been exposed. Look at the community level of the incidence of COVID-19. Our social distancing must be practices. We're still going to be doing standard precautions. Plus, remember what we talked about on the very first webinar all those few months ago, is that the papers and things that were in your waiting room that could not be wiped down should go away. And things in your waiting room should be able to be disinfected. So we've gotten rid of the paper. We are in the process of ordering seamless waiting room chairs so that they can be properly disinfected, and we already have seamless dental chairs. A screening questionnaire should be made available for patients prior to and during appointments. You should be able to have a contactless thermometer to check for patients' temperature. And I think a really important area and an issue for my program is a designated place to doff and don. And that is very important because of the ability, you want to come into the room as prepared as possible, and you take the materials off. You also want to be as safe as possible. And then making sure that you have an EPA-approved disinfectant for virucidal work. So as always, it's been an honor to be here with you. I look forward to your questions as always. And now it's back to Gary to go over some of the latest technology. Thank you, and here you go, Gary.
Thank you, Dr. Reznik, for the clinical update. When I heard that you were going to cover the CDC guidelines for facial hairstyles for use with respirators, I had to give a little heads up to Paul Fierstein, who I think is everybody's favorite bearded dentist. But as you can see, Paul sent me some photos and shows you way ahead of the curve. He went with the circle cut with a chin trim. So you're all good. Thanks for leading the way, Paul. Now we want to turn to a little bit of a refresher on the air management and what Henry Schein has to offer. As you know, a few weeks ago we did an air management overview as well, but didn't specify any products. But now we're excited to share some of those details of some of the solutions. In a previous webinar, we introduced the Office Protective Equipment category, OPE, and under that one subcategory is air management. And we certainly know it's topical today to talk about it, and we know aerosol-producing procedures when we're clinically, we know high-speed, ultrasonic, air-water syringes can create those. But it's also become relevant that speaking or speaking in a loud voice is an aerosol generating procedure. So it generally covers the entire office, from waiting room to front desk to even the team lounges, but certainly chairside clinically. And we have numerous regulatory bodies that are voicing in and giving recommendations. The one you may not be familiar with is ASHRAE, which is the American Society of Heating, Refrigerating, and Air Conditioning Engineers, and it covers the HVAC, but they've dealt with this air management all along. And as we'll see, the different boards and different recommendations that come from these regulatory bodies are primarily recommendations. Even the state by state, you have to look at your state regulations as well on air quality if that comes into play. But most recently, we know of the CDC, and they've mentioned specifically portable HEPA air filtration units, which we'll focus on as well. The FDA has also mentioned air purifiers with new guidelines there, as well as OSHA. As dental professionals, you have employees, so OSHA covers that. CDC and others will cover in ADA recommendations of how you treat your patients. But OSHA now is engineering controls in dental offices, which include high-efficiency air filters. So it's certainly become top of mind when we look at it. And when we look at the methodologies of air purification, whether it's in a consumer model or a medical model, basically you can categorize them for simplicity's sake as filtering devices or inactivation, essentially destroying it. And if you talk about air filtering, you'll hear terms of HEPA, MERV, carbon filters. These capture the bacteria, some viruses, and any of the air pollutants. UV light, and it's called UV germicidal irradiation, can inactivate the viruses and bacteria as long as certain criteria are met. Photocatalytic oxidation is also becoming popular to talk about, and that's oxidizing these air pollutants. And then providing ionization in the air, actually putting negative ions out there that can gravitate towards the positive pollutants and bring them to the floor out of the breathing airway. And as always, as we've mentioned, it's important to consider bundling. Infection control is an additive process, so if you do one thing, it's good. If you do two things, it's probably better, and you have to find a point of diminishing return, essentially. But the EPA mentioned source control, which what we can do as clinicians, use rubber dam, high volume evacuation, consider digital dentistry and not looking at impressions, or air drying or using air water syringes on impression materials. So some areas that we can take control of to eliminate or reduce the aerosol leaving the mouth. When it does leave the mouth, and again in the mouth, high volume evacuation captures 90 to 95% of the aerosol when it's in the mouth. But again, we've seen the introduction of some technologies that will use extraoral suction. Consult, as the CDC recommends, consult with your HVAC technician if there's any way to control it centrally around your office. And then air cleaning, and this may be room by room or centralized as well, and we'll go over. And when you have some considerations, you probably want to learn about the different methods. Again, the CDC has recommended HEPA filter devices, so you look at different HEPA, different filtered devices. Using a carbon filter gets rid of odors and some volatile compounds. UVC is the lower wavelength in the UV range, and that's UV GI also in the ionization. So just want to give you some background into what you're looking at. And when you have these air filters, they all provide a cubic feet per minute rating, or that's airspeed basically, and many of them offer different speeds. And you need to know that CFM of how often you're changing the air essentially. And then certainly you want to know the size of the rooms, open or closed format. Many times you look at just the square foot, meaning length times width, but you do have to take into consideration, and it's always better if you take into consideration the ceiling height and get the cubic feet. And when you have that information, the CFM and the square foot, you can then determine what your air change per hour is in that area. If it's not a closed room, you have to estimate a little bit more, but if you position it correctly, you can get a pretty good accurate information. And so when you know the CFM, when you know the volume of the room, you can figure out the air changes per hour. So if we just take, for example, a 10 by 12 operatory with 8-foot ceilings, that's 900 cubic feet. And if we took 60, because that's per minute, and we want to figure it out per hour of the system in times CFM, and this system has 4 different air speeds, for example, from the low speed of 144 CFMs to a high speed of 383. And you can see that if we take the lowest speed times 60 divided by 960, you get 9 air changes per hour. If you take the highest speed, you get 24 air changes per hour. So every couple minutes you're getting, or a few minutes, you're getting the complete air change there. So that's an important criteria when you look at your space and consult with people of what system do you really want to look at. And you can find that. You can go on the Henry Schein website. We have something on the air management category, which is a calculator that will do this automatically. And you can run through what-if situations based on your room, whether waiting room or operatory. Just by entering in feet and the flow rate of your air purifier, it will tell you the number of air changes. There you see it. You can also work backwards and come back out and say, okay, I know the CFM of the air purifier, and I want to, figure out what size room can I accommodate with that air purifier, based upon the number of changes that you want to accomplish. Or if you know the space and the desired number, you can figure out what CFM that you need. So it's pretty simple to sit down and really figure out with the specifications of air purifiers. The other thing you want to also take consideration of is sound level. Normally when you have it on a higher speed, the sound level will be higher. Most of them are between or below 60 decibels, which is a dishwasher or human conversation. So it shouldn't, and certainly below what we typically have with high-speed handpieces and other devices in the operatory. So a nice constant sound level is nice. And then with filters, you have replacement costs. With UV lights, you have replacement costs. So when you consider it, look at some of the specifications of what the continued use costs over time is. Now, when we look at this, and again, nothing is mandated by any of these regulations, but here are some systems to consider that Henry Schein has offered. And as you're probably very well aware of, with PPE, they're scouring the world to find the proper PPE for dentistry, making sure everything is proper. And we do the same thing with air purification systems. And we'll go through these fairly quickly. Again, these are only based on recommendations of these governing boards of using air purifiers, and certainly you have to determine what's right for your office. But one of the areas that we found, and based upon how South Korea has reacted to the pandemic, one of the quotes from the WHO, China Joint Mission, says, as the pandemic continues to spread, understanding the lessons learned from South Korea's national COVID-19 response strategy is critical. And so one of the products we found and technologies that we've found was actually initially funded by the South Korean government in response to the 2003 SARS coronavirus. It's very important to know that very few of these systems, and we don't think any, have really looked at the newest coronavirus, the one that's causing the pandemic now. But many of them have used different strains and proven effectiveness. So when we look at this company was started in 2003, and it was a joint venture by universities and government bodies. And currently it's present in 80% of all the hospitals in South Korea, 85% of the universities, 70% of all the health centers in South Korea, and more than 370,000 commercial installations in South Korea alone. It was the winner of the Best Innovation for Infection Control in the U.S. in 2018, and it's proven against many of them. We'll show you some of that data. So it's very key to look at single pass, so there's no circulating of pollutants. And as they quote, the highest certified clean air technology in the world. And essentially, for dentistry, they have 3 different models, one for large waiting rooms, one for smaller waiting rooms and operatories, and then a small office, front desk, home use option. So you have many. And it uses what's called virus killer technology, and we'll review that. Again, they've proven through different airborne viruses. Again, important to note, one of the coronaviruses, but not the COVID-2, that hasn't been tested yet, but something that's very resistant as well. And then bacteria, fungi, and mold, different areas, and have proven to be single pass, none detected. So when we look at these different options, you can see that most of these systems will combine multiple modalities of filtering and oxidation or ionization. This one, the one that's recommended for large waiting rooms or open clinical areas such as ortho clinical areas, uses a HEPA filter. It first starts, the air goes through from the bottom, goes through a pre-filter to capture some of the larger pollutants, then goes through a HEPA filter and a carbon filter for the odor. And then, as you can see, it goes through an activation chamber, that UVGI, that light, you can see the UV light that's shielded. And in there is UVC lamps and titanium dioxide filters. And when that happens, it creates, that's the photocatalytic oxidation, creates oxides, and as the air passes, in a single pass, the pollutants are destroyed. And it has a very laminar airflow, so not so much turbulence as it comes out. It covers a large area, low sound volume, a digital display, and one of the nice things, this can be wrapped too with your office customization. So this is recommended for large areas. And as you can see, nice aesthetics, and gives the indication to the patients that you are taking control of the air. Now, in operatory settings or something that with less than 700 square feet, this is also one that can be used. It draws the air in from the sides and below, away from the patient and dental healthcare professional, and then again exports it out to the sides along the walls. It can be wall hung, freestanding, or put on a TV stand. Ideally, it's at the foot of the chair, about 6 feet away from the foot of the chair, but you can position it between operatories and otherwise. So again, has the same virus killing technology that's used. And so you can see very low sound level as well. And very aesthetic, and again, gives a digital display, tells you when filters need to be changed. And then for small offices, or even ideally set right up on the front desk, is the Hextio by Radicate. It has the same technology that's used, UVC lamps, titanium dioxide filters, so it uses not only the filtering but the photocatalytic oxidation for small areas. And that can be actually portable, battery powered if you need to travel or have it, want to bring it with you someplace. Now, the company that's probably made the most noise and positive noise over the last 10 years in air quality in North America is a great Canadian company called Surgically Clean Air. And they've come out with a smaller version of what originally was their Cascade unit, down to per room nice system called Jade. Now, Surgically Clean Air is listed in 2019 and 2020 as some of the fastest growing companies. It's used in all the industries, including hospitals, dental office, commercial, sports teams also have them in their locker rooms. Now, the Jade was recently introduced as a practical air purification system for operatories and home use, as well as waiting rooms. And all total, just in the past 10 years, they have over 20,000 dental professionals being energized or being experiencing the air purification of the surgically clean air systems. This is the Jade. As you will see, it uses the HEPA filters, the MERV filters, carbon filters, photocatalytic oxidation in a real compact design. And if you've seen any articles in air quality over the past 10 years, it's probably focused on this type of technology from surgically clean air. So very good and very well proven. Again, they have 4 speed options and a low sound and a very ergonomic and practical application. Pure Breeze by Vaniman. Now, Vaniman's a company that's had a long history with Henry Schein. They use a MERV filter in a portable. It's on casters, so you can move that around with different speed settings and low sound. If you go to the Vaniman.com page, they also have a calculator as well as a room settle time calculator. I think from the CDC it came that you need to allow 15 minutes between patients. This will really also give you a sense of how much time you need to clean the air. So you can look on the calculator, enter in the information that you need, and it'll tell you how long until all of the particles have settled out. The AF400 by Quattro, again, has been utilized for some time in dental laboratories and others, and now bringing it into the office, has casters, low sound level, and purification methods. It's a filtering process as well. Another area is using photocatalytic oxidation to oxidize the particles. The ADP 70 by OSHA can be wall mounted, that's the top one, or set on a counter somewhere. They also have internal ductwork that you can insert in your existing HVAC system and get all the air that's passing through oxidized and clean. And finally one, the VidaShield by Medical Illumination, takes it a little different, and it's a in-ceiling installation. It can be used with fluorescent or LED lights or no light. And what it does is bring in air through a MERV filter, a low-level MERV filter that will capture the large particles, but it'll allow the smaller particles to go through parallel to a UVC light. And so as it goes through, the airflow is close to and parallel to a lengthy UV light, so it has a good dwell time there, and then exports out the air on the other side. So this can take it up and away from the patient breathing area. It's just a little bit of a refresher in some of the products that are offered there. Again, every office and need is unique, so consider bundling and looking at different procedures, including the source control, the ventilation, and the air cleaning. And as we know, every office is unique in dentistry. Every specialty has different aerosol-producing procedures, the number of team members, the patient flow throughout the office, whether the office is open or closed, the design of the office, and certainly the square footage that you need to clean. So take all of these into consideration, and there is not one recipe that fits everybody, but probably need to look at what's best for you and your practice. Thank you again for attending. And as always, if you have any questions or concerns or topics for future episodes, please let us know at webinars@henryschein.com. And please subscribe to our YouTube channel to make sure you get the latest notifications. And finally, I hope this week finds everybody and everybody's community safe. I have a daughter who's a missionary in Guatemala, and this week sent me an early Father's Day gift, reminding me to say, stay safe and stay informed. Thank you.